Friends, welcome to my hospital at Ranaghat, India. In this case, I had two challenges, Intumescent cataract, and the pupil became very small after capsulorhexis, after the minirhexis. Here it is. By this time the capsule has been stained, the main incision has been made, the capsule has been stained with trypan blue dye, and now the dye is washed out. Adrenaline has also been applied, but initially the pupil looks adequate, but see what happens. After injecting viscoelastic substance, the pupil is quite well adequately dilated. And now I make two side ports, one on the right side, this one on the left side of the main incision. And now I incise the capsule and make a small C-flap, a curved flap. Hold this flap and the capsule tends to go to periphery, but since I aimed for a small rhexis, I could easily bring it back and complete the minirhexis. Now I am aspirating the superficial peripheral cortical lens matter, and thus I am decompressing the capsular bag. I am decreasing the intralenticular pressure. See, lot of cortical matter is coming out just by tapping on the nucleus. And as I am doing this, the pupil has started becoming small, and the pupil size of the pupil is about 4 mm at this time. And this is not adequate to do the adequate sized rhexis. The size of the pupil is not adequate. So I am using B-hex pupil expansion device. Here it is. The B-hex forceps is being used, 23 gauge B-hex forceps, which opens vertically. Here it is, how you tuck the flange. Now I am going through the right side port, holding the flange at on o'clock and tucking it. That's it. Now I have to go through the left side port, use my left hand and tuck this flange which is at 10 o'clock. Dear colleagues, we must train our left hand for a lot of maneuvers. And now visco is injected. Now a Vanna scissor is used to make a small cut at the margin of this small rhexis, and with the help of this Utata forceps, now I am performing an adequate sized capsulorhexis. I am not in a hurry, and here I complete the rhexis. It's a fairly round, adequate rhexis. And now is the time to introduce the tip of the phaco handpiece. This is a very minimally edited video, and you have to spend about 12 minutes to watch this full surgery. And this is direct chop. Hold the nucleus firmly and chop it. And this nucleus is very brittle and it is getting divided very easily. And now each nuclear fragment is worked on with ultrasonic energy and it is emulsified and removed. The machine being used is Oatley Cataract 3. Phaco power used is 50 to 60%. Flow rate is 45 ml per minute and vacuum is 450 millimeter of mercury. This is the last portion of the nucleus and it is emulsified and removed. The iris is at its original plane. This pupil expansion device doesn't change the plane of the iris, so surgery is as usual. Now viscoelastic substance is injected. A Simcoe cannula has been used in this case to clean the cortical matter. Very minimal amount of cortical matter is remaining in this case, but we must meticulously remove the cortical matter, whatever is there. And now I go through the left side port and remove the cortex which is there from 9 o'clock to 11 o'clock. Now I go through the right side port and remove the cortex which is between 11 o'clock to 2 o'clock. And now a foldable intraocular lens is to be implanted. Viscoelastic substance has been injected and this is a hydrophilic acrylic intraocular lens. We must be gentle at this time. The lens should not push the pupil expansion device. Sometimes it can get dislodged and go behind the iris. However, it can be easily taken out holding the flange which is above the iris anywhere. And now the device is being untucked. It is brought in anterior chamber and very easily it can be pulled out. And now the viscoelastic substance that has been used to implant the intraocular lens has to be cleaned very nicely. It has to be removed very nicely so that intralenticular pressure remains normal. I irrigate with a 23 gauge Simcoe cannula. Go behind the lens and irrigate the capsular bag. Just by this irrigation, most of the viscoelastic substance, say about 60 to 70% visco, comes out. Unless we remove the viscoelastic substance very nicely, the intraocular pressure may shoot up, may be raised, and the patient may even have pain. Patient may have steamy corneal edema next day, and that is a lot of discomfort for the patient. So we must be very meticulous. We must remove the visco very nicely after implanting the intraocular lens. In this case, there is one or two lens fibers which is there at around 11 o'clock. So I have taken bimanual irrigation aspiration and I am trying to remove those fibers. But here I have caught the iris, but doesn't matter, surgery is over If the pupil becomes small now, it doesn't matter. So the visco is being removed very thoroughly. And the pupil is looking very nice. There is no sphincter tear. This is a bit of moxifloxacin. Now the side ports are hydrated. The stroma on either side of these stab wounds are hydrated so that these stab wounds close. And now a final lavage of the anterior chamber is done with BSS with the help of a Simcoe cannula, and the case is concluded. Here it is. And when you form the anterior chamber, this is the last step. Give the Simcoe irrigation at the main wound, and when you come out, just lift the anterior lip. This is the key. Hold it like this and lift up and come out. And the main incision usually doesn't require any hydration. See, all the wounds are nicely closed. Thank you very much for watching. Hope this video will help you in developing your surgical skills. Be a great surgeon and serve the mankind with great skills.